Great.
Hi, Lisa. How you doing? And welcome to all. How you doing today?
We're wonderful. Another great Q&A webinar. We always have fantastic questions rolling in, and we will be giving away another IVF cycle, of course, after this. The winner will be emailed directly by myself, so you can check your email for that. And this session will be recorded, so if any questions come in that we don't get a chance to answer, since we usually get quite a few, be sure to look for more videos, and we'll do our best to answer them, and you can take a look after this as well.
And I'm Dr. Rob Kiltz, and this is Lisa Stack, who's our support at CNY Fertility. And I'm one of the docs, the owner-director at CNY Fertility Centers. We have centers in Albany, Syracuse, Rochester, and Buffalo.
Absolutely.
And we've been in business for over 20 years and seeing clients from around the world. And one of the things that we offer, I think is different, is integrating Eastern and Western medicine, and all of our locations have on-site acupuncture, yoga, massage, and that's really, I think, something that sets us apart from many other fertility centers.
It truly does. We have a fantastic program here. We truly integrate and we keep it affordable, which is one of the many reasons that we love having these sessions, to be able to share that information and spread the word.
Well, I started this 20 years ago, and I always thought IVF was way too expensive out there, and I started at 2000, and right now we offer IVF for as little as $2,900 for a cycle, and we're doing egg freezing for $1,900, which is pretty amazing. Now, there's medications and monitoring that most people have coverage for, but really we're here to do our monthly webinar to share and let you go ahead and ask questions, and we'll do our best to answer as many as we can. So why don't we get into that, Lisa?
Let's get started and send as many questions in as you have. So first question, I'll be 40 next month and been on 12 Clomid cycles with 1 chemical pregnancy, 3 failed IUIs, 1 case of hyperstimulation, etc. Do you think I should prime for a month and do an FET? With my age, do you think I should do PGS?
Well, let's see. So 40 obviously is in the more advanced age for fertility, but there's still plenty of women conceiving at age 40.
Absolutely.
With the history, I recommend moving beyond Clomid, and frozen embryo transfers more and more seem to be much more successful than the fresh embryo transfers. So preparing the body for pregnancy, and any losses or failed implantation, I believe, is related to the immune system. And we've been really talking about the baby diet, bacon, eggs, butter, beef, yes, which is a lot of ketogenesis. So if you haven't read about ketogenic diet, I highly recommend it. Maria Emmerich has some great stuff, but what I recommend is try to keep it really simple, okay? And the other things that we add to the implantation enhancement, along with the frozen embryo transfer, would be a scratch procedure or hysteroscopy, endometrial scratch, intralipids. We're really adding a lot more intralipids, which is basically adding fat to the system. Fat reduces inflammation, and natural fat like bacon fat, pork fat, butter fat, and beef fat seem to be the best. So certainly I think that frozen embryo transfers work best. Do you do PGS? Well, PGS is basically biopsying an embryo at usually the blastocyst stage and then cryopreserving it, and then waiting for a week or 2 until you get the results on whether or not they're chromosomally normal or abnormal. And then taking those normal embryos and transferring them. Now, it's not a perfect science, and there's some cases where you may have mosaicism, and you may get back an abnormal embryo based on the placenta, but not the actual embryo itself. So I'm a little skeptical about it. It adds cost that you may be simply able to save by placing the embryo in. But I would say that they can go either way. I think focusing on the immune system for the sperm source and the egg source, so maybe this is where that priming part comes in. Do a ketogenic prep, a baby prep, and then do a frozen embryo transfer with a full immune enhancement with things like Prograf, with Lovenox, prednisone, even Neupogen, and weekly intralipids can be really helpful.
Great. So in addition to prenatal vitamins, is there anything else that our clients should be on in regards to supplements?
which supplements to take. Well, we know that many of us are vitamin D deficient,
Yes.
and a lack of vitamin D can have an adverse effect on sperm and egg and implantation. So by adding 2,000 to 4,000 units, but get a vitamin D check, and it depends on the lab, but typically between above 25 to 30. Lots of sunlight, but not too much, obviously. But if you're adding a lot of fat and some protein, and really reducing the carbs, because carbs cause inflammation and may adversely drain a lot of that. So vitamin D, CoQ10, which really helps the mitochondria out, and we know the mitochondrial function is critical in the egg and sperm function. And then fish oil, so adding the fish oil, omega-3s, but I say eat the fish. That's the best supplement you can get. Eat something fresh and whole with lots of fat. For some women who we believe may have some diminished ovarian reserve, adding DHEA, 25 milligrams 3 times a day. And Dr. Gleischer had wrote some papers on that at CHR. I think that's some really good stuff that we're finding some success with that. And then folic acid, I think, is really important to help reduce neural tube defects. I think that kind of covers most of them.
Great. So the next client will be traveling to us from out of town. I'm wondering how that process works in regards to tests being sent, and additionally, if all the tests could be done under ovarian dysfunction because of lack of insurance coverage.
Well, in essence, ovarian and sperm and dysfunction is really what we have here, and I think that's relevant. I personally believe immunologic dysfunction is also another great diagnostic code. Because infertility, because of insurances, that may be an issue. Endometriosis, metabolic syndrome, polycystic ovarian syndrome really help. But 50% or more of our clients come from more than 2 to 4 hours away. It really is a lot easier than people understand. And in truth, you need a lot less blood testing than you think you do. Much of what we do relies on follicular ultrasounds and making decisions based on the development of your follicles. A trigger shot today is with Lupron, some Avidril or HCG, and then clients fly or drive to CNY Fertility in Albany and in Syracuse, where we offer really the most affordable fertility care. And I've been really proud of our success rates, and we do not exclude anyone from doing a retrieval or a transfer. We don't pick and choose people based on their ovarian reserve or their age or their weight or other conditions, where I'm really disappointed that so many centers are turning people away because they believe they can predict who will and who won't get pregnant. And I don't think we as doctors are capable of that. So really, we have a global travel team led by Donna and Becky and Justine and Greta. But in truth, our nursing teams are really pretty amazing, and we're able to help manage and monitor our patients from around the world.
They are, that's true. Is there any baseline that this client would need to do for a priming month, stim month, and FET?
So the priming month, we've been talking a lot about priming and preparing the eggs and the sperm and or the uterus prior to implantation or egg retrieval. We've been using a lot of estrogen, human growth hormone, for about 30 days to prep and prime the eggs, along with ketogenic food plan, if any other supplements like the vitamin D. We've been recommending acupuncture and yoga, visualization, really very helpful in the process. And so by doing that in the month before, and guys, you need to cut away the beer. You need to be focusing on the ketogenic, the baby diet, bacon, eggs, butter, beef, because it really helps prep the sperm. And so by doing that for either a fresh retrieval or even a frozen embryo transfer, it gets the whole body prepped. Whether you're infertile or not, I believe these are all processes that really will help improve pregnancies and reduce miscarriages altogether.
Wonderful. How do you
Did that answer the entire question?
It did. How do you decide how many embryos to transfer for an IVF cycle?
Well, in general, we're recommending freeze all cycles. So for most women, that they should plan on freezing their embryos anywhere between day 3 and day 6, so either at the cleavage stage or the blast stage. If you have 4 or fewer, we're doing a lot of day 3 freezings. If you have 5 or more, we're doing a lot of blast freezing. Under 35, first or second transfer, we recommend 1 embryo. One and done is what we're all moving towards. And now that we offer a $3,900 IVF cycle, which includes the freezing, thawing, and transfer of all the embryos from that cycle until you deliver a baby, it really makes it much more affordable and accessible for more and more people. And so 2 embryos is our sort of max for anyone under 40. Under some very rare circumstances, we would offer 3, but that's very rare under multiple failed cycles and poor quality embryos. And one of the interesting parts about our qualification of an embryo, you can't look at an embryo and really say it's going to be a baby or not. So you have to be very careful about that process as you're thinking about that.
Absolutely. What is the success rate of those who have had a laparoscopy versus those who have not?
Laparoscopy, is it part of the normal evaluation and treatment process for infertility? I believe it is. Yes. I was at Francesca's restaurant in North Syracuse recently, and a client of ours was about 6 months pregnant, and all we did was a diagnostic laparoscopy, found a little bit of silent endometriosis. We cauterized it. There's an argument between excising it or cauterizing it. We've seen so many conceive in a short amount of time. She conceived in 2 months.
Wonderful.
Today we did 3 laparoscopies. I found endometriosis in all of them. And we believe that's the first step for many.
Absolutely.
Now, what are the symptoms of endometriosis? Well, guess what? Infertility and miscarriage and failed implantation is a common symptom of pelvic endometriosis.
Absolutely.
And quite often we're simply finding a little bit of scar tissue, some inflammatory changes that we can clean out at the time of a diagnostic laparoscopy. At our Syracuse CNY location, we do in-house laparoscopies, but we also use Krause Hospital in Syracuse, and our doctors in Albany and Buffalo all perform these at our local hospitals. It's an outpatient procedure. It takes about a half an hour to do. It's a small, mini laparoscopic procedure that really doesn't take any time at all and really helps tremendously. So I recommend talk to your gynecologist about doing that. Small fibroids can be factors, and endometriosis can be all a factor.
Wonderful. Next question is about natural killer cells. If this woman's fertility doctor doesn't believe in it, should she go to her OB for testing?
Well, I believe that the immune system is the #1 cause of infertility, implantation failure, and miscarriage. And it may be related to chromosomally abnormal embryos, aneuploidy, because the immune system adversely affects the mitochondria, the DNA, every part of our bodies, the implantation site. Natural killer cells are normal in our body. You have to have just the right amount. You have too many or too few, it could be an adverse effect. The problem is that the testing at any one moment is imperfect. C-reactive protein, Th1, Th2, looking at markers for clotting factors can be really important. But ultimately, I think that if we're not finding an obvious answer, and we rarely do, it's going to be the immune system more than anything else. There's some testing that we do through Repro Source, which can be helpful, or Allen Beer Center can be helpful. But if the numbers come back normal, it may be our ability to measure the thing that matters for you is not so good. Empirically treating with Intralipids, IVIG, Neupogen, Prograf, and recently we've been sending a few patients to either Nogales, Mexico, or more commonly the Markham Center in Toronto for LIT therapy, and we've had some really great success in those cases. So I tend to be more of a proponent for treat over testing, because the clinical diagnosis matters more than anything. But it is simple enough to check NK cells, and if it makes you feel better, then it should be done.
Absolutely. So next client is wondering, how many days do we suggest taking off for an IVF, especially in regards to the egg retrieval or the embryo transfer? Another question about days off for injecting medication, which you wouldn't need to take any time off for injecting medication. That would just be a daily medication that you could take on your own time. So how many days would you suggest for rest, for retrieval and transfer?
Is this after? I guess I'm not understanding the question.
How many days of work would you take off around the time of egg retrieval, after egg retrieval?
So you don't need to take any time off except the day of the retrieval and maybe the day of the transfer, but we have people traveling on those days, and there's no evidence that taking time off matters. But if it matters emotionally for you, then I think it's really important. That's something you should do. So the emotions are really the most critical part, because stress, I think, is what gets us more than anything in anything else in life. But fertility, it's such a powerful push against us. So if you need the time, I mean, we are welcome to give you whatever time you need. And if you need a note that you need some rest, you got to take it. And if it feels like you need it, then do it. And for many of our clients who are coming to us and they have very rigid work hours, we have lots of early morning patients and lots of early morning appointments. We see many clients right before shifts start. We see a lot of nurses and teachers first thing in the morning. We start at 6 a.m. every single day. And in some cases, I'm here usually at 5 o'clock in the morning. But we start seeing patients at 6 a.m. at our locations. And again, our patients come from around the world, and you don't have to be here for the consultation. We do a lot of Skype and FaceTime, so you can get a chance to see us and see who we are and what we do. I'd say we're different than anyone else, because we're really open to understanding that our clients are in charge. We're the consultant. We're here to give advice. We're learning so much from our patients. Really, the ketogenic and paleogenic diets and the inflammatory process, we've learned from them. We are reproductive immunologists, and we've learned through the years of experience and years of the practice out there. But the more and more I'm learning about reproductive immunology, stress reduction reduces inflammation. Acupuncture, yoga, prayer, meditation, reduce inflammation. And the number one cause of inflammation are carbohydrates. And fat reduces inflammation.
Absolutely. So another question about travel. What's better for our traveling clients? Only come up for the retrieval and the transfer, or staying through until after the embryo transfer?
We have some patients that come up for the entire monitoring process and stay until transfer. Remember, more and more we're recommending a retrieval and a freeze-all. But also we do a lot of IUI cycles, we do a lot of intercourse cycles, so we help manage and monitor clients with repetitive losses. They don't necessarily come to us. They're able to have a lot of their treatments with their local OBGYNs. And we work with them. We work with infusion centers and home nursing. But mostly a lot of this, what we do is we're your coach. We're helping you coach in the process that you may never have to see us, other than you get a picture on our webinar on our website. But We have the Loft 42,
Yes.
which is our CNY Fertile Retreat Center, where we have a space for many of our clients to come stay and retreat with us right on Lake Skaneateles.
Absolutely.
And I'm working on providing that more and more. We have some local hotels in the area that provide really great
Wonderful
service. You fly in, you drive in, they'll drive you to our office both in Albany and in Syracuse. And we're opening up our new Buffalo IVF center coming soon. We already have our satellite where Chris Ziegler and Dr. Arroyo are seeing clients for monitoring and insemination and immune modulation in the process.
Absolutely. Would you suggest doing HGH or HCG injections?
HGH and HCG injections, well, human growth hormone we're using for the priming of the eggs prior to an IVF retrieval. We're using it anywhere between 14 and 30 days prior to the stimulation. And then we're using enduring stimulation, and we've seen such a great improvement in those that have had previous failed cycles, poor egg or embryo quality. And I can't tell you why. One of our colleagues in Spain presented this at our Baltimore meeting last year at ASRM, and I was really impressed. We've been using it and seeing a great improvement. It does add some cost, but there are a few things that I really recommend, and human growth hormone is one of them. It might help the guys and the sperm. We haven't used it yet. HCG, we're using a combination of support in the luteal phase. We're using intrauterine to help it increase the implantation of the embryos. It may be reasonable in IUI cycles because an embryo's got to get there also. And it may be reasonable even in intercourse cycles. So when we talk about priming, we need to be not just thinking about IVF. Many people don't have coverage for IVF, or they don't want to do IVF.
Absolutely.
We have to think that all these methods are available at every single stage, whether it's natural intercourse, IUI, IVF, and certainly even if it's preparing eggs for use in an embryo that's going to be used in a gestational carrier or a surrogate. Because at CNY Fertility, we do offer that for many of our clients.
Absolutely. So the next client has heard that there is a New York grant for IVF. Is that still available, or can you talk a little bit about our grant program?
Well, New York State has a grant program that you have to have New York State insurance, and we have money available, and all you have to do is call us and ask about it. Also, people don't even know this, that we have our own financing, and we really, at $3,900 for a standard IVF, there's nothing down. You pay 6, 12, 18, 24 months. If you need longer, we're very flexible. Our job is affordability and access and quality. We've been working on that for years.
Absolutely.
And I think that's why we're in the top 10 IVF centers in the nation. In New York, we're way up there. Our IVF success rates really are I believe, top notch. Our frozens are much improved, but you have to remember, those numbers are non-comparable, and even when they're non-comparable, we've done quite amazing, and I've really been proud of our team. Center of Excellence, CNY Fertility, is that, and we're really working to spark the energy that New York State and United Healthcare and Optum and everyone knows that CNY Fertility is one of the top centers in the nation, and we want all of our clients to recognize that we're here to help them.
Absolutely. So how much does embryo grading on day 3 impact the likelihood of success? Is grading a good indicator of embryo quality?
Well, I'm not a big proponent of embryo grading because it's a fashion show and judgment. Since embryos are constantly in motion and we may be seeing it in the midst of a division, it's not so good. So every embryo that is dividing has the potential to become a baby, I believe, should be given that opportunity. One of the things that I'm seeing happening is many IVF centers are basically, oh, it's no good, let's throw it out. And so consequently, we're only saving the very best embryo, only freezing those people that have the very best embryos. So we're judging an embryo and never giving it a chance. And I don't think we're capable of doing that. So it may be giving us a little bit of an edge in understanding what are your odds, but it's not 0 or 100. It might be more likely or less likely. But I believe our job is to help every embryo have its chance to become a human child.
Absolutely.
And that's what we do at CNY Fertility. We don't throw away a ton of embryos. We don't select our patients. And we know that SART's CDC data has a disclaimer that you shouldn't be comparing because we're all populations are so different.
Absolutely. Absolutely. So do you still recommend FETs or freeze-all cycles if you only retrieve 2 to 3 eggs?
Well, if you're retrieving only a limited number of eggs, so maybe you're doing a natural or a mini stimulation cycle for either intercourse, IUI, or IVF, and as long as your stimulation is light and your progesterone levels are low on trigger day, then doing a fresh transfer is still reasonable, transferring 1 or 2 embryos, and then freezing any additional embryos. We're finding a lot of day 3 embryos have an excellent chance of becoming a baby, and we're also holding many of those to day 5. So the freeze-alls, you know, there's nothing that is right for everyone, and that's the one thing at CNY Fertility. We're here to tailor the treatment for individual patients. Not everyone wants to do IVF, and so we're going to tailor your treatment, whether it's natural intercourse or it's going to be assisted high-tech and the whole kit and caboodle. Really the process of freezing and transfer as individualized, we are recommending for the higher stimulated cycles more to freezing. We're offering more blast freezing cycles. We're doing a lot more PGS, but it really needs to be individualized.
Absolutely.
Did that answer the question?
Yes.
Good.
Do you need an endometrial scratch if you recently did a laparoscopy?
A laparoscopy doesn't necessarily mean you had a hysteroscopy and a biopsy, but if you do a hysteroscopy with a laparoscopy and you do the scratch, and it's the cycle prior to the transfer cycle, because really the scratch matters for the transfer cycle, not the retrieval cycle. So I think it doesn't need to be done if it was done, but if it wasn't, and you had a hysteroscopy and it was normal, then you might only just do the endometrial scratch procedure. Remember, the studies are all over the place. No one knows the right answer, but I always say, if what you're doing isn't working, shouldn't we do something different and be open to all the possibilities? Because we've seen so much success, even when some people say, wow, the studies don't prove that. The same thing goes for laparoscopy, but we've seen so many patients conceive and deliver a baby. I think it's valuable. Hysteroscopy, biopsy with laparoscopy, I think is a good procedure. And then the other is just a hysteroscopy biopsy or just an endometrial scratch with a biopsy.
Good. So the next client will be 32 in August and will be doing her first FET in August as well after a failed fresh cycle in June. When should she start Intralipids?
So I think the Intralipids should start at least a week or 2 prior to the embryo transfer, and then should be done every week or 2 until about 14 weeks.
Great.
This is very empiric. There are really no good prospective randomized double-blind placebo-controlled studies. But if what you're doing has failed, let's try something, do something else, and we've seen such success for it. Inflammation is the #1 problem for all of us, and reducing it is done with fat. And if you can't do it with mostly the baby diet, then add the Intralipids. We have some that go to 24 to 26 weeks, even IVIG monthly, starting the month prior to the transfer. We think it really is valuable.
Absolutely. So next client has a good question. She's 29 and has PCOS and endometriosis. She's had 5 pregnancies, 3 miscarriages and 2 chemical, and all have ended in a loss. She's already tried IVF with PGS, and she's also done prednisone, Intralipids, and Lovenox. Is there any hope for her? Is there anything else that she can do?
Never lose hope. Always have positive energy. And faith is probably more important. I really believe that that's something we all should practice, meditation, and persistence, even in the face of it doesn't seem like it's ever going to work. If you haven't done a laparoscopy, hysteroscopy with looking for endo and ovarian acupuncture, also known as ovarian drilling, it really helps. If you haven't done the baby plan, bacon, eggs, butter, beef, I really recommend ketogenesis. If intralipids haven't worked yet, add the IVIG. You might even think about looking at Humira, LDN, low-dose naltrexone. Ovasitol through Theralogics really helps a lot for metabolic syndrome. And if you haven't done the FET cycle, frozen embryo transfer, along with a little more aggressive, might be even Lovenox at 30 milligrams twice a day, prednisone 10 milligrams twice a day. And if those things aren't getting you there, always think about a gestational carrier. Did that kind of touch on all those? I want to make sure I touch on those. Fertile fatty foods first. PGS is helpful, but my bias is if you make the embryos, give them a chance, but it really is something that can be helpful, and be a little more aggressive with the IVIG, the Prograf, Neupogen, Intralipids, and maybe even the Humira and as a part of that.
Great.
Oh, and then the other is even 2 to 4 weeks of antibiotics. We're finding that there are a lot more subclinical chronic inflammation infections that a combination of Doxy and Z-Pak for 14 to 28 days for you and your partner could be very helpful.
Those are all great points. So if a frozen cycle seems to work better, do you ever suggest freezing all and not doing a fresh transfer?
I often recommend freezing all and not doing a fresh transfer. You know, it's a hard thing to convince our clients, but we're working on that more and more. Sometimes we have enough embryos, we'll do a fresh, although we're really holding back and wanting to do a frozen. So many clients travel a long way. It's hard for them to get back. They want that chance. And I talked to a lot of my colleagues. Many of them are still doing fresh transfers, giving our clients the option because it's their body and their pregnancy options and their embryos. And we can't be so dogmatic and restrictive that we're not giving them the chance to decide. So we are recommending. In a $3,900 cycle, you still get the freezing, the thawing, and the transfer. At the $2,900, you get a single embryo transfer with the fresh, more mini, and then the $1,900 cycle is for the egg freezing part of this. Now remember, there's the medication part that many clients have coverage, but we're working with King's and Freedom and Apothecary and others where we're really getting a lot of assistance by some of the pharmacies that can help reduce the cost of these medications. What was the other point I wanted to bring up in this? Monitoring.
Yes.
Many of our clients have coverage for the monitoring. But we offer a very reasonable price if you show up locally, but your local OBGYNs, you got to talk to them, you got to ask them, can you do it? And we'll help work with you and give them the guidance and direction of how to do this. And there might be some resistance, and the fertility docs that you have, we're willing to work with them also. There might be some resistance, but if you don't ask, it's always a no. As long as you ask, you're giving everyone an opportunity, can you help participate with us? They might learn something different and help us make fertility care more accessible and affordable in this country.
Absolutely. So is there an age limit to the clients that we see and treat?
I don't create an age limit for anything or anyone. You'll help us know what the right thing is for you. If we create the age, You know, there are plenty of younger that seem older and older that are a lot younger.
Yeah.
And age is not in what you see, but it's in the mind. And so we don't have that hard, fast rule. Let's talk, because we can help one way or another.
Absolutely. When doing Neupogen, what should my WBC be?
White counts. I've had a lot of conversations with Jeff Braverman, excellent reproductive immunologist. We've learned a lot from Dr. Braverman.
Yep.
And you know, quite often we're going as high as 40 to 60, and it seems like it depends. It's scary, but we have not had any issues as of yet. But careful monitoring and is important in this whole process.
Great. Can you speak to the need for genetic screening prior to IVF or donor egg and donor sperm IVF?
Well, most people in this world do not have genetic screening before they have a child, and the chances of having a genetically abnormal child is less than 2%.
Yep.
That said, we now have technology that we're more and more recognizing that there's a bank of 100 or 200 tests that can be done. Is it worth it to you to get the information? It's had some cost to the process that may delay your treatment for one way or another. And if it's positive, then your partner should be tested. And ultimately, the risk is still probably pretty small, but we're recommending, and I say we're offering it more and more so our couples, individuals can have some sense of what their options are. Yep. I think it's a little scary. We often do too much testing in the process. Medicine is adding cost to testing, and yet we just need to make you aware of the opportunities. And more we're offering it today for donor eggs, donor sperm, and certainly for everyone out there. That because it's not enough just to try to figure out what your risks are. Today, we really don't know where our genes come from. We all come from the same place. Our risks may be pretty equal.
Great. So the next client has been losing weight and currently has lost 20 pounds. When should she start seeing changes in her cycle, and how can she change her current exercise routine because she's come to a standstill on her weight loss? With all of this, she's also eating a fairly clean diet.
Well, I hope all of us are eating a clean diet, because eating dirt is not what we're really meant to do. My bias is that you want to eat fresh, fatty, fertile foods, and your body will find its set point. My bias is a little bit against exercise.
Yep.
Walking, yoga, meditation is probably more important. There's no evidence, I believe, that exercise is good for us. It's actually fight or flight. It may be pro-inflammation, not anti-inflammation. It may be more harmful than good. Cortisol, epinephrine are stimulated, and our hunger goes up. And so most of us who are trying to find that, to get down to that weight, I did this, I lost 30 pounds down to my high school weight, no exercise, and I haven't been exercising in 5 or 6 years now. I've been pretty amazed by it. So if you're gonna go walking, spend time with your partner.
Absolutely.
Spend time out in nature. It's really important to do. And so if you're finding that you're at a plateau, my bet is you're eating too many carbs. And remember, kale, Brussels sprouts, broccoli, asparagus, yogurt is all carb. It's all sugar.
Yep.
Fruits, fiber, greens, and grains are bad for us. And that's the hardest part to understand, that they're all carbohydrates. They turn into sugar, inflammation, stored as fat, and our body is really smart. You eat a carb, it's trying to store it as fat, and it's not going to let you get away with it. If you haven't read Gary Taub's Good Calories, Bad Calories, and Why We Get Fat, I highly recommend it. Then Keto Clarity and Cholesterol Clarity by Jimmy Moore, amazing. And then Maria Emmerich, who's keto adapted. But keep it simple. Bacon, eggs, butter, beef, fatty fish, that's it. And eat the fat. Put butter on your steak.
Absolutely.
Eat the fat. Fat is the best energy source. It's what we burn. We do not burn sugar. And what's amazing is our body requires 0 carbohydrates, 0, to function at its best level. The ketogenic diet is best 80% fat, 15 to 20% protein, and 0 to 5% carbs. Fiber is a source of bacterial and yeast overgrowth in our gut. It causes inflammation, infertility, Crohn's, colitis, endometriosis. I believe that's what the cause of cancer, obesity, heart disease, and diabetes. And so it really is a challenge to get, since we've been so ingrained with grains.
Absolutely.
Did that answer that?
I believe it definitely did. Thank you. So the next client has a beautiful 16-month-old, thanks to CNY Fertility, and she's currently breastfeeding. She has borderline PCOS, and she is thin, but does have polycystic ovaries and does not ovulate on her own. She has frozen embryos, but she can't do a cycle until she stops breastfeeding. In the meantime, what can she do to help jumpstart her body? And do you think Lexapro would be a good option to try before starting a whole frozen cycle? She has no lining.
Lexapro?
Maybe not Lexapro. Maybe
Letrozole?
Letrozole, probably.
Well, breastfeeding may have an adverse effect on getting pregnant and luteal phase, ovulation, but plenty of women get pregnant breastfeeding. And Letrozole, Femara, we use more than Clomid today.
Yes.
We believe it really has a positive effect on ovulation. The ketogenic plan is like, I go right to that, fertile fatty foods. Babies want fat, and that's why they really thrive on that. Breast milk is really high in lactose, sugar, because babies want that part of it.
Absolutely.
And then the fat. So I would say that light walking, yoga, spend some time with your partner, your family, your friends, get out in nature. That's the best preparation. And then the Letrozole really will help. Now, if it's a frozen embryo transfer, is that what we're talking about here? Either Letrozole ovulation transfer or even just when you're ready, estrogen, progesterone transfer is the best route to that.
Great. So the next client was on the keto baby diet for 9 months and had her first successful implantation after 6 transfers. She lost the baby and has fallen off of the diet over the last few weeks. How long should she be back on the diet before she transfers again to ensure her immune system is on track?
Well, we don't really know the time of that, but really the 30 days, and I'm really sorry to hear about your loss. And these are the hard parts of this process, is that when you lose something, you finally get to that point, it's devastating. And talk to someone. Support group. Share your story, journal, read about it. Very important. But certainly, I 30 days is my number. You know, and I'm making it up. It might be a week, it might be 3 months. But it really is, get a trash can, throw away all the food in your house, and then you go buy fresh eggs, cream, bacon, butter, fatty meat, fatty fish, and that's really it.
Absolutely.
And if you don't get rid of the stuff, I mean, we're carboholics. Cocaine is like what we love. And what's interesting is sugar stimulates the brain as much or more than cocaine, and we want that stuff really bad. So, you're feeling down, what do you want to feel better? You want a carb, you want cake, you want bread, you want pasta. Boy, it makes us feel good, doesn't it? And so by really cutting out those carbs, but adding fat, that's really the key to all of this.
Absolutely. Many clients find it uplifting and helpful to kind of overhaul their diet and focus on getting their body ready back in again after having a loss, because many clients feel an absolute loss of control after they lose a pregnancy, because there's nothing that you can do to prevent that. Really, it's up to your body. We can help you as much as we can with medications and supplements, hormonal supplements, but many clients feel that loss of control after a pregnancy loss. Focusing your energy on really nurturing your body to get it ready for another cycle can help you bring a little bit of that effort and that control and that energy back and help you with the grieving process.
frustrating, but somehow use that energy to move forward and seek the help in the process.
Absolutely.
And we have a great support group. Our global team is there to help. And whether you're a patient or not, we're here for everyone, and that's what we want you to know.
Absolutely.
And we're really working on growing that team. And there's so many CNY Fertile Friends out there.
Absolutely.
The CNY Fertile Friends is really how we continue to grow, and it's pretty amazing how we've grown to one of the top 10 IVF centers in the nation. And again, great rates. And it's simply, I think, because I have a great team, word of mouth, and we're open to the integrative approach.
Absolutely. So the next client and her husband will start the process of IVF next month. She's 31 and really nervous because of the injections. What can I do to minimize this anxiety?
This is easy, and I am doing it. And you write it down. This is easy, and I am doing it. I am really grateful for the baby we're having.
Absolutely.
And you write these things down, and you simply visualize the outcome, and you keep on repeating and writing, this is easy.
Absolutely.
And through the practice of that, and then someone's going to help you with that first little teeny tiny needle that is literally quick and easy and done, and wow, I can do this. But the first thing to do, we use the term fake it till you make it, and it sounds cliche, and be positive, and I'm a little crazy about that, everyone knows. Really what we're working to do is simply begin in the mind. The mind is the creator of our reality. And that's where visualization, and put a vision board, pictures of you, your partner, yourself, your family, your children that you dream about.
Yes.
And it's amazing how the brain helps bring those particles together. And this is easy. And so with that, our team will help you through it. A little bit of ice, and boom, it's in. They're tiny needles. And we have ways that some people don't need the intramuscular needles. I mean, we tend to use them a lot more, but really all the studies show that the vaginal routes, but a lot of what we're doing, even with the frozen embryo transfers, is completely natural cycles. So if we can help you ovulate naturally, or with letrozole, we can really restrict a lot of those shots. That's what we're really working to do. Easier, friendlier, and affordable.
Absolutely.
And CNY Fertility is really the national leader of affordability. And no longer do patients travel to Czechoslovakia or some other place. They travel to upstate New York. And because we're much more affordable, place to stay, and even in the wintertime, it's a great and easy to get around here.
It really is.
And this is the kid from LA who found that upstate New York, really, they know how to plow. And
it's no big deal for us.
It's really very easy. And the airport, to get to Syracuse or Albany Airport, and sooner Buffalo Airport, is really much simpler than people understand.
Absolutely. And we do have nurses on call 24/7. So if it's 10 o'clock at night, you're doing your injection and you can't remember properly how to do it, we have an access to wonderful videos on our website in multiple languages, and we also have a nurse on call 24/7 to walk you through it if you need that help.
And remember, even if it's just how do I do it, I need just to talk to someone who needs some support, because really, the words are the critical part here. We need the words from someone to say, okay, let me help you through it. And it might even be we get you on FaceTime and we help you through the process.
Absolutely. So how do you determine if a patient needs FSH only or FSH and LH for stimming? I noticed that for some women, too much LH can cause damage to eggs. Is this true?
That's what they say. Is it true? For some people, there's not a lot of good data to tell us who's the right person or not, because we've used straight FSH for years and done well. More and more we're adding Menopur, or we're adding HCG, and it seems to be helping in those patients where it didn't work before. I would say our general protocol is a 225/75 of going left and Menopur. We're using also some HCG, a 300 and plus a little 10 to 20 units of HCG. Part of that is cost preference, ease in the process, and so it's not always a straightforward answer here that we can draw blood and say, aha, based on this you need this. We do pontificate a lot as if the studies tell us the right answer, but I call it lies, damn lies, and evidence-based medicine. Medicine in general is a fashion show. Many people are claiming to be the very best, and in fact, they're making it up. And there are a lot of great doctors out there that are providing great fertility care.
Absolutely.
And really, it might take just something very simple. So I would say in general, we're recommending it a little, not a lot, but we're doing our donors pretty much with straight going left FSH and doing really well with that. So
great. When traveling from out of town for IVF, how close to the retrieval date do people normally book their flights? Cost for last-minute tickets is scary, but booking too far in advance is also scary because things can change.
It all can change, you're right. In general, most patients are scheduling their, we're anticipating the retrieval. We can know between 7 and 10 days ahead of time on average. We have some ways with birth control pills and timing to try to really help people get here at the right time. I would say that 85 to 95% of the time it works just rock on. 5 to 15% there's a little bit of leeway, but travel in America is pretty good. We're not walking. It is pretty amazing that our clients really make it 95 to 99% of the time.
Absolutely.
And we're here to help make that travel, and our Global Connect team, and we have a lot of really great assistance with that. So, start playing around with it. Even if you flew to Buffalo or Toronto or New York, the driving distance isn't that far. We've had some patients that wound up doing that and either took a cab, Uber, or the train and managed to get here quite readily on time. So usually getting here the day before a retrieval or even the day of a transfer has worked tremendously well.
Absolutely. Do we have open embryo donation?
We do have open embryo donation. So getting more embryos is really the key. What I'm working to do is get a groundswell of more and more couples, individuals donating embryos, whether it's open or anonymous, and donating sperm. My goal right now is CNY Fertility Sperm Bank is let's get more people donating sperm, donating eggs, so we can pass along the reduced costs and make it more affordable and accessible. We're donating blood, we donate kidneys. Egg and sperm donation is not that right now. It's pay for your eggs and pay for your sperm or pay for your embryos. Really, we need to be getting a groundswell of people out there going to your insurance companies, going to the press, going to your elected officials, and really speaking out about, hey, we want to make fertility accessible and affordable. We want there to be more eggs and sperm and embryo donors, but you got to talk it out. Simply, hey, we're looking for an egg donor or somebody to donate embryos or sperm. Can you help us? Remember, if you don't ask, it's always a no. You at least put it out there. I think it's a yes. So we're definitely working and we're open to that. If you know someone, most of it is someone knows someone that wants to donate some embryos, and so that's already open. So if you're throwing it out there, hey, does anyone have any embryos available? We'd like we need them. Can you help us? And you're getting that donation. Hey, we need some sperm or eggs, and we'll help do the screening, and they become your eggs and sperm, and in that, it's really a lot cleaner process, and really is egg and sperm and embryo donation.
Absolutely. So the next client travels quite a bit for work. Do you have any recommendations for travel during IVF? Her next trip is scheduled for hopefully just after her next transfer.
So, most of us aren't riding horseback or running or walking long distances to get to our work, and so our ability to travel actually is easier than you think. You're sitting on an airplane going 300 miles an hour, and you're not going anywhere in your seat.
Absolutely.
But so I don't think the travel is as harmful as people. I don't think it's harmful.
Yeah.
I think the stress of it is more harmful. But if you could kind of sit back and realize, you know, I could do this. This is easy. Because look at all those people traveling that are getting pregnant naturally, and they don't even know where they're at. So maybe if we begin to imagine, hey, IVF and fertility assistant is more natural than I ever imagined. So is driving in a car and a plane natural? That's not. But it feels so natural. Maybe we need to begin to recognize that maybe all this fertility treatment is a lot easier and a lot more natural than I ever imagined. You de-stress, you get pregnant, or while you're going through the process, it's a lot simpler and easier. So
absolutely. So the next client is 32, and her AMH is 2.45. She was on 75 of Menopur and 225 of Gonal-F. Only 6 eggs were retrieved and only 5 mature. Did her body not respond to the medications properly?
Well, is there more to that?
And can she add something else to create more follicles?
Okay, so more is not necessarily better. Getting 6 and 5 is excellent. And so the ovarian stimulation process, if you want to make more, you go higher doses, maybe 300, 150 in that, and that you do a little bit more of the priming with the acupuncture and yoga and meditation and the baby diet. The bacon, eggs, butter, beef, ketosis really, really matters in this. So those are the things that are going to help you. But 6 eggs is excellent. 5 of them mature is amazing.
Absolutely.
And we've done some natural cycles. We got 4 eggs, 4 mature, 4 embryos, 2 transferred, 1 baby, and we got 2 in the freezer. So imagine that what you produce at the moment is perfect. Then you feel better, and that you're fertile, and all of this is affordable. I always say put $50 in the bank a day. That's about what you'd spend if you had a baby in your arms. Fertility is more affordable and accessible than we imagine. And certainly at CNY Fertility, my mission and my foundation that I started this practice is affordability and access. I will continue doing that despite what I believe the rest of our colleagues are doing out there. But many of them some of them are beginning to come over and really working to try to make this affordable, accessible, and natural.
Absolutely. Absolutely. Well,
What else?
thank you. So the next one, how does the protocol differ from women who only have male infertility factor? So what do we do differently?
Well, there isn't an only in any of this because it takes a sperm and an egg and a uterus and an environment to conceive. And so we can't forget that. So we're always approaching it as a combination of how do we improve the sperm, how do we improve the eggs, how do we improve the embryos, and how do we improve the environment. So it really is going the same direction. Men, keto. We're using a lot of Clomid, HCG, acupuncture. Get rid of the alcohol. Really cut down and get rid of the carbs. Fruits, fiber, vegetables, I think are detriment. A low fat, filet mignon is not what you need to be eating. You need to be eating prime rib. And so our approach really is always comprehensive and global and looking at both sides. Because if we say, oh my God, it's sperm, we've seen plenty of couples where the guy has no sperm, we have to get it out of the testicles, or they need donor sperm, and they're not getting pregnant. And it's like, well, gee, what are we missing here? Well, we shouldn't miss anything. We need to make sure we're thinking of all sides. That's why HSG hysterosonogram. That's why ultrasound and blood testing on the female side. That's why focusing on the fertile food plan is very, very, very critical.
Absolutely. Now to follow up with male factor for our last question, the next client has male factor, specifically morphology issues. Would the female be on less medication? Touching on that, and how would you treat it?
Well, we're going to treat the woman based on her ovarian reserve and her age and what the ovary looks like, her AMH, and their desire to do more natural, fewer eggs, mini, or is it really a standard cycle where we're getting 8 to 15 eggs, we're looking at a freeze-all cycle in that process. So I think it's similar to the last one, that you can't just say, okay, it's a sperm issue and we're going to go that route. So it really is a comprehensive approach.
Wonderful. Well, thank you so much.
Did that answer that question appropriately?
Yeah, yep, absolutely.
And there are a lot of questions, and we're not getting them to all today. We apologize. And I do a lot of a lot of people text message me. I pass it on to our nursing team. I'll handle some of those directly. My cell is 315-416-9872. We have 250 fertile staff members that are part of our team that are really global. And our mission is to help you conceive naturally without ever seeing us here physically, or through assistance in coming globally to one of our locations in upstate New York.
Absolutely.
We're partnering with OBGYNs across the country and around the world that they can help you in the process to really get there. And you know, I really want to help all of us.
Absolutely.
And share the word. How can we do better? And how can we help our insurance companies and our employers provide the care that is global? And that we can recognize that reproductive endocrinologists are really globally working hard. And in general, they're all great. And they're providing great care. And we want to help elevate our profession, that they begin to listen more to a comprehensive, integrative approach, Eastern and Western.
Absolutely. Well, thank you so much for answering all of our questions, and we truly appreciate the feedback. Contact us at any time, especially if you need emotional support. Feel free to contact me. I can help connect you with all of our fantastic staff members and all of our resources that we have available to you.
CNYfertility.com, excellent website. We're always looking to improve it. Our Fertile Friends, our Facebook.
We have our Facebook group.
And really we're here for you, and you have to tell us what we can do better. Please tell us what we're doing wrong. And you know, sometimes I don't want to hear that, but we need to hear it for us to improve.
Absolutely.
And that's kind of the mission that we have, and it really is grassroots, and we're here for our clients. You're number one. So thank you for supporting us. We really appreciate it.
Thank you.
God bless.